Vasectomy is a highly effective modern form of male-based contraception that involves a minor outpatient surgery under local anesthetic. The procedure stops sperm from leaving the body by closing the vas efferens, which are the tubes that carry sperm out of the body. The major types of vasectomy are conventional or no scalpel. Conventional vasectomy involves numbing the scrotum with a local anesthetic, cutting both sides of the scrotum to reach the tubes, cutting and removing a small part of the tubes, and sealing them using dissolvable stitches or allowing them to heal on their own. No scalpel vasectomy involves numbing the scrotum, puncturing a tiny hole in the scrotum to reach the tubes, and sealing or tying the tubes. No scalpel vasectomy is less painful and results in less complications compared to conventional vasectomy. The procedure is mostly permanent, but worth pointing out is that if reversal is conducted within 10 years of the procedure being undertaken, the success rate is about 55%, while the rate drops to 25% after 10 years. Vasectomy as a form of birth control has been gaining popularity over the recent past. For instance, over 15% of all American men above 40 years had had a vasectomy in the 1990s. About 12% of married American men under 40 years have had a vasectomy that was conducted when they were below 40 years. An estimated 33 million men worldwide have already undergone vasectomy. Other sources estimate that over 50 million men all over the world have had a vasectomy. In America alone, over 500,000 vasectomies are performed every year. Studies associate the prevalence of vasectomy with age, race, and education. Particularly, vasectomy is more common among white men, with at least a high school diploma, and living in the Midwest or West. Prostate cancer is the most common cancer and the second most common cause of cancer-related deaths among men. Prostate cancer is pretty rare before the age of 50, but after 50, the incidence and mortality rise exponentially. The disease has a positive relationship with age, considering that over 60% of patients with a positive diagnosis are over 65 years. 58% of prostate cancer is attributed to genetic factors, thereby making the disease hereditary. Mutations of individual genes such as BRCA2 increase the risk of prostate cancer. Gene mutations are commonly inherited by offsprings. Noteworthy: men with a close relative who has been diagnosed with prostate cancer are twice as likely to be diagnosed with the disease. Those who have 2 or more relatives are 4 times more likely to be diagnosed with prostate cancer compared to those who don't. This risk is even higher if the diagnoses were made when the family members were above the age of 60. Additional prostate cancer risk factors include diets low on vegetables and high in processed meat or saturated in fat, which increase the likelihood of obesity. Overweight men are at greater risk of developing aggressive prostate cancer. Recovering from surgery takes longer for obese men, a phenomenon that raises the risk of dying from prostate cancer. Obesity is also associated with hypertension and diabetes, with both conditions being linked to prostate cancer. Apart from dietary factors, other socioeconomic factors that influence the development of prostate cancer include occupational exposure, access to health care, and concerns over health matters. Factors associated with aggressive prostate cancer include tall height, high calcium intake, family history, Agent Orange exposure, and the black race. Black men have the highest incidence of prostate cancer around the world, with an increased risk being reported in North America, the Caribbean, Scandinavia, and Britain. Black men are 75% more likely to be diagnosed with prostate cancer compared to white men, and twice as likely to die from the disease. Dividing ethnicity further reveals that individuals of African descent are more likely to be diagnosed with prostate cancer compared to those of non-African descent. Over 11% of men are projected to develop prostate cancer at some point in their lives. Prostate cancer is the most common cancer among black men, with the rate being 140 in 100,000, compared to 99 per 100,000 for white men living in America. The prostate cancer mortality rate among black men is 50 per 100,000, while it is 23 per 100,000 for white men. 122,000 men were diagnosed with prostate cancer in 1991. With 32,000 losing their lives because of the malignancy. Just to take you back a bit, Agent Orange was a tactical herbicide used by the American military to clear leaves and vegetation for related operations mainly during the Vietnam War. Veterans who were exposed to Agent Orange, of course most if not all of them being men, have been diagnosed with various terminal illnesses, especially cancer, over the years. The illnesses include bladder cancer, chronic B-cell leukemia of the white blood cells, Hodgkin's disease or cancer of the lymph nodes, liver, or the spleen, non-Hodgkin's lymphoma that affect lymph glands or the lymphatic tissues, multiple myeloma of the plasma cells, prostate cancer, respiratory cancers including that of the lungs, and some soft tissue sarcomas that affect muscle, fat, blood, lymph vessels, and connective tissues. Other illnesses include amyloidosis that affect the heart, liver, and the kidney, chloracne which is a skin condition, type 2 diabetes, hypothyroidism that causes joint pains, obesity, infertility, and heart disease, ischemic heart disease where the heart does not get enough blood, Parkinsonism that causes irregular movements, Parkinson's disease that affects muscle movement, peripheral neuropathy that causes numbness and muscle weakness, and porphyria cutanea tarda that causes liver failure. Agent Orange is a very interesting topic on veterans issues, of course most veterans being men, that requires a whole video and will be covered sometime in the near future. Of special interest in this video is the relationship between vasectomy and the risk of prostate cancer, so back to that. Most common contraceptives used today have disadvantages that are rarely discussed. For instance, oral contraception use in women is associated with increased risk of breast cancer. However, the need to move away from conservative values into the so-called liberation, which includes sexual liberation, often guides the shadowing or shelving of contraception information that does not support liberal views. The exact etiology of prostate cancer cannot quite be mapped, but has largely been linked to reproductive histories. The inability to accurately map the etiology of prostate cancer is associated with the fact that the disease is poorly understood and highly under-researched. A man's risk of prostate cancer diagnosis has been associated with their reproductive history, with increased risk being linked to a low number of offspring, low ejaculation frequency, and low sperm quality. Vasectomized men have an increased risk of prostate cancer, compared to non-vasectomized men, with this risk persisting for at least 30 years after the procedure was undertaken. Particularly, vasectomized men are 15% more likely to be diagnosed with prostate cancer compared to non-vasectomized men. Men with a history of vasectomy have a 10% increased risk of prostate cancer, with a 19% risk of other lethal diseases. Among highly screened men, the risk of lethal disease is 56% higher for those with vasectomy. The 30-year prostate cancer risk is not dependent on the age of the individual, the stage of initial cancer diagnosis, which could either be low advanced stage diagnosis, socioeconomic status, and visits to the primary healthcare provider. The absolute increased risk of cancer in prostate-specific antigen or PSA screening found that the risk of prostate cancer significantly increases with vasectomy. Prior to PSA screening in the 1990s, a significant number of men were diagnosed with advanced prostate cancer. The use of PSA screening results in diagnosing most cancers as indolent and low risk. Worth pointing out is the fact that increased screening frequency raises the risk of a positive prostate cancer diagnosis, which lowers the risk of a lethal disease over time. Regularly screened men report additional healthy behaviors. Men who constantly consult clinical professionals for a vasectomy are more likely to go for prostate cancer screening. Smoking is associated with increased risk of advanced stage prostate cancer. Other studies suggest that smoking is minimally associated with vasectomy, with 75.3% of men who have had a vasectomy reporting ever smoking compared to 71.8% of men who had not had a vasectomy. Among smokers, vasectomized men had smoked an average of 24.3 years, compared to 24.7 years for non-vasectomized men. Vasectomized men have a lower frequency of diagnosis with other cancers compared to non-vasectomized men, indicating that vasectomized men are generally healthier than the rest of the population. The increased risk of prostate cancer, and not other cancers, is a reflection of the underestimation of the prostate cancer risk, considering that vasectomized men have a lower likelihood of drinking and smoking, thereby having a lower risk of other cancers. Vasectomized men also have a lower risk of cardiovascular diseases and colorectal cancer, which are all related to high-fat diets. This phenomenon indicates that fat intake is not that much of a problem in the case of vasectomized men, and as such, cannot account for the elevated prostate cancer risk. Vasectomized men have similar or lower rates of other medical conditions, compared to non-vasectomized men, including hypertension. Men who have had vasectomies 20 years earlier have an 89% elevated risk of prostate cancer. The risk is greater for men who had vasectomies after the age of 40 years. The long-term elevated risk of prostate cancer 20 years after a vasectomy is replicated by a number of studies. The low prevalence of vasectomies in the Black community, and the elevated risk of prostate cancer raises some questions surrounding the relationship between the procedure and the disease. However, in whites and combined study groups of blacks and whites, Vasectomy is associated with an excess risk of prostate cancer only among individuals who had a vasectomy before the age of 35 years. Individuals with a 30-year vasectomy history are 4.4 times more likely to be diagnosed with prostate cancer compared to non-vasectomized men. Some studies suggest a stronger relationship between the risk of prostate cancer and age at which vasectomy was undertaken compared to the number of years since vasectomy. The age-adjusted risk of 2.2 is observed in men who reported a vasectomy 13 to 18 years before a positive prostate cancer diagnosis. Prostate cancer patients report a greater likelihood of reporting a history of benign prostatic hypertrophy, as well as having undergone transurethral resection of the prostate to solve obstruction issues. Prostate surgery to solve urinary obstruction does not have a relationship with vasectomy. Other studies associate vasectomy with testicular cancer. Testicular function might reduce the proliferative potential of the prostate. Thus, active testicular function is protective against the development of testicular cancer. Some studies argue that the vasectomy-related prostate cancer risk is minimal, but the risk is elevated for high-grade and lethal diseases, including distant metastasis or death. Critics of the positive association between vasectomy and prostate cancer have cited detection bias because, as mentioned before, men who opt for a vasectomy exhibit other health-related positives, including constant checkups, especially with urologists. Also, the possible confounding effects of sexually transmitted diseases and infections have been cited as a source of bias. However, studies citing detection bias does not account for the relationship between vasectomy and the higher risk of advanced or lethal diseases. The risk of prostate cancer is reduced with each kid fathered, thereby highlighting the association between infertility and prostate cancer. High ejaculation frequency in the early and the midlife significantly reduce the risk of prostate cancer. Sperm cell concentration has an inverse relationship with the risk of prostate cancer. It is often hypothesized that the malignant potential is reduced either by the constant passage of testicular secretions through the prostate gland through ejaculation or systematic hormonal mechanisms. These mechanisms support research findings suggesting that long-term hormonal imbalances and testicular interstitial fibrosis following vasectomy procedures raise the risk of prostate cancer. Alternative biological mechanisms explaining the relationship between vasectomy and prostate cancer revolve around reduced secretion of the prostatic fluid after vasectomy or the post-vasectomy immune response to sperm antigens. These antigens possibly cross-react with other tumor-associated antigens, as well as suppress tumor immunosurveillance mechanisms. It is unlikely that the vasectomy-prostate cancer relationship is founded on changes in plasma hormone levels because plasma testosterone levels remain unchanged or increase modestly after vasectomy. As a matter of fact, increased levels of circulating plasma testosterone raise the risk of prostate cancer, and men with high testosterone levels are more likely to have undergone a vasectomy. Studies suggest that prostate cancer development is hormone-dependent, with this dependency being evident with the increased risk of cancer with the rise in testosterone levels. Vasectomy alters prostatic function without involving the levels of serum hormones. A permanent reduction in the volume of seminal plasma dihydrotestosterone following vasectomy is a common occurrence because of reduced secretion from the prostate gland. The volume of the peripheral prostatic zone is smaller in vasectomized compared to non-vasectomized men. A common vasectomy prostate cancer hypothesis suggests that altering the prostatic function adversely influences the flow of androgens from the epididymal testes complex to the prostate via the vas deferens or the deferential vein. Stasis of fluid in the lumen of the prostatic glands increases the exposure of the prostate gland to carcinogenic components of the lumen fluid. The reduced rate of fluid flowing through the prostate after vasectomy, and also with aging, raises the risk of prostate cancer. The constantly highlighted carcinogenesis arises from immune responses to sperm following vasectomies. Some malignant cells contain embryonic differentiation antigens, with tumor growth increasing after immunization. Enhanced tumor growth arises from blocked antibodies or tumor suppressor cells that cross-react with antigens found in the tumor and embryonic tissues. Sperm cells express antigens that might interact with the embryonic tissues and other malignant cells. The incidence of malignant cells increases dramatically after vasectomy, which is associated with anti-sperm immunity. High antibody levels, and the reaction with sperm antigens, is also linked to other cancer forms, including neuroblastoma, breast ductal carcinoma, squamous cell lung cancer, and melanoma. The function of the prostate gland appears to return shortly after vas deferens reanastomosis in vasectomized men. The serum explanation to the vasectomy-related etiology of prostate cancer is replicated by various authors, with some suggesting that serum steroid hormone profiles do not experience changes after vasectomy, with some of the minor delayed changes including loss of seasonal variation in serum luteinizing hormone, estradiol, and testosterone, and abnormalities in serum gonadotropin response. As mentioned before, vasectomized men report higher levels of spermatozoa antibodies because the procedure disrupts the barrier system that sequesters germ cells and other reproductive components from the rest of the body. These antibodies are associated with increased occurrence of tumors in the liver and the lungs owing to a rise in the anti-sperm immunity. Increased antibodies to sperm in prostate cancer cases, as well as in cases of other genitourinary cancers and of benign prostatic hyperplasia, suggesting that their finding reflects a host response to aberrant genitourinary cellular alterations rather than a causative factor. Vasectomy does result in significant morphological changes, but a drop in seminal plasma volumes, the ejaculate contents in citric acid, plasma, and zinc, polyamines, spermidine and spermine, but not the precursor putrescine, is reported 8 years after the procedure. Noteworthy, polyamines are central components in cellular membranes that mark cell turnover. After vasectomy, some semen proteins are upregulated, while others are lost, a phenomenon that affects prostate carcinogenesis. For instance, decreased expression of TGF-B and TGF-beta in semen following vasectomy has been observed. Transforming growth factor beta signaling has been implicated in an inhibitory role in prostate tumorigenesis. Infertile men are almost 3 times more likely to be diagnosed with high-grade prostate cancer, which could further explain the relationship between vasectomy and prostate cancer since the men become infertile. While increased ejaculation frequency has been associated with reduced prostate cancer risk, irresponsible sexual behavior could raise the risk of a positive prostate cancer diagnosis. Men with high testosterone levels are likely to be more sexually active, thereby having to undergo vasectomy as an approach to fertility control. Increased sexual activity raises the risk of contracting sexually transmitted diseases that are associated with prostate cancer. Vasectomy also has a relationship with serologic evidence of sexually transmitted infections because some infections are associated with vasectomy and prostate cancer. Notably, vasectomy is positively associated with human papillomavirus, HPV, while prostate cancer is linked to D. vaginalis and human herpes virus type 8, HHV8, also referred to as Kaposi sarcoma herpes virus, KSHV, infections. Most HPV is harmless and goes away by itself, but some types could lead to genital warts and cancer. Viruses are known to cause up to 20% of all no-human cancers. HHV8 causes vascular malignancy and multicentric Castleman disease, MCD. HHV8 is a lymphotropic virus that undergoes replication in epithelial cells in organs, blood vessels and the skin. HHV8 has been isolated as a cause of skin malignancy Kaposi sarcoma, KS. 20–30% of gay men are HHV8 seropositive compared to 1% of HIV-1 blood donors. The virus is associated with the reception of anal intercourse, with HHV8 genes promoting spindle cell proliferation that eventually leads to tumor transformation.